Hello everyone, welcome back to our channel, and in today's session we are going to learn about sickle cell disease. I know you've heard of it quite often, but for today's session we are going to understand what sickle cell disease is, what are the risk factors, how does sickle cell come about to be, and how it presents, that is clinical features. And we can also look at the prevention or just understand more about sickle cell. So it's just going to be an overview, not too much details. So for sickle cell, first, it's a genetic disease. It's an autosomal recessive inherited hemoglobinopathy. So basically it's caused by the mutation of the beta globulin gene on chromosome 11. I won't go into much details about that. So this mutation, it will result in the production of this hemoglobin S. There are different types of hemoglobin. We have hemoglobin A, that is adult hemoglobin, hemoglobin F, fetal hemoglobin, hemoglobin S, the sickling, and there are others, okay? So this hemoglobin S, I'll just call it HbS, polymerizes under low oxygen tension, causing the red blood cells to appear rigid and sickle in shape. So normally the red blood cells what is this shape called? I don't want to call it circular, but something like that for easy understanding. But for sickle cell, they appear curved, So the normal is a bit round, then the sickle cell red blood cells appear curved. So we are going to see what causes them to appear that way. So for the genetics, as we've said, mutation on the chromosome 11. So on this, we have the glutamic acid or glutamate. It's replaced by amino acid called valine at the 6th position of the beta globulin chain. I won't go into much details again about that. And we'll have a scenario. Example, we have two carriers or two traits. We say HbA, it's normal adult hemoglobin, and HbS, it's the sickled hemoglobin. So if we have AS and AS, the father is AS and the mother is AS, so they're going to give birth in case, let's take an example, they give birth to 4 children. So if we have an AS and an AS father and AS mother, 25% of these babies will be normal, 50% will be carriers, and 25% will be sickled. Example, 4 children. So one child will be normal without the trait, without the disease. 2 children will be carriers, will have the trait, and one child will have the sickling, will be a sickler, will have the sickle cell disease. Another scenario, if we have father who has sickle cell and a mother who is normal, so all children born will have the trait but will not have the disease. If we have one normal and one sickled. If we have one sickled, example, the father is sickled and the mother is a carrier. So they'll give birth, example, if it's 4 children, 2 children will be sickled and 2 children will be carriers. Hope that's understood. You're going to listen it after this for better understanding. So what is the epidemiology of this sickle cell? It's mostly prevalent in the sub-Saharan African. So in Kenya, since I'm in Kenya, sickle cell is more prevalent in malaria endemic zones. That is the lake region and the coast region. The prevalence of sickle cell is higher in this region because of malaria. All right. So approximately 300,000 babies are born annually worldwide with sickle cell disease. So that's quite a significant number. And for the next thing, we're going to look at the pathophysiology, how this disease comes about. So there are three mechanisms. One, we have the hemoglobin S polymerization. Two, we have the chronic hemolysis. And three, we have vasoocclusion. So one, beginning with the HbS polymerization. So when there is reduced oxygen tension, we are going to look at the risk factor, what causes reduced oxygen tension. Example, uh, increased activity or exercises and all that. We're going to look at them. So when there is a decreased oxygen tension, the HbS molecule will polymerize so that the RBC will become rigid and sickled. Okay, so they say initially sickling it's reversible, but it comes permanent after repeated episodes. So after repeated episodes, it's irreversible. So for this, when the red blood cells are sickled, their lifespan reduces to around 10 to 20 days. For a normal red blood cells lifespan, it's about 120 days for a normal adult red blood cells. But when the red blood cells is sickled, as I've told you earlier, the normal RBC, it's a bit round, and sickled, it's comma shaped. If you know a comma, yeah, comma shaped. So sickle cells tend to have less survival days, that is 10 to 20 days. Okay, so the consequences of this, there'll be chronic anemia, jaundice, and pigment gallstones, and increased erythropoiesis. Because of the reduced lifespan, there'll be increased hemolysis. So increased hemolysis will lead to jaundice, will lead to anemia. Increased destruction also leads to increased production, that is erythropoiesis. So there'll be a mismatch on the processes. Then the third one, it's vasoocclusion. So these red blood cells, as we have seen earlier, that they become rigid and sickled. So when they are rigid, they obstruct the small blood vessels, leading to tissue ischemia, because when there is occlusion, there is not enough blood reaching the tissues because of the occlusion to the small blood vessels. So it leads to tissue ischemia, it leads to infarction that causes the severe pain crisis. You've heard of people with the sickle cell disease, they tend to have episodes of severe pain. This is caused by the vasoocclusion. When the small blood vessels are obstructed because of the sickle cell, there is tissue ischemia. And if blood is not reaching the tissues, ischemia leads to pain. Okay, so what are the risk factors, or what are the precipitating factors? We have hypoxia, that is reduced oxygen, and dehydration, acidosis, infections, cold exposure, high altitude, and stress. So when a person has a sickle cell disease and they are exposed to such infections, you're going to look at the types of infections and acidosis, and when they are dehydrated, when they are exposed to cold, they tend to have a crisis. So all these factors predisposes them to have the crisis, and we are going to look at the types of crisis. There are about 7 crises. We are going to check them out. So what are the clinical features? One, the general, we have pallor, because we've said that there'll be anemia due to increased hemolysis and all that. We'll have fatigue. They just features, general features of anemia: pallor, fatigue, jaundice, growth retardation, because like there is inadequate blood supply to the tissues, there's delayed puberty, there's poor weight gain, and there is the painful or the vaso-occlusive crisis, which is the most common feature of this crisis is the pain. These people like undergo like too much pain, so they have to be maybe in opioids and something like that. And they can also have severe bone pain, joint pains, swollen hands and feet, chest pain, abdominal pain, like just a lot of pain. So for the acute chest syndrome, the features include fever, chest pain, cough, hypoxia, respiratory distress, the difficulty in breathing, and all that. Yeah. So for these patients, this is the number one, or it's the most common leading cause of the death, the acute chest syndrome. And we also, okay, we are going to tackle the different crises a bit. There are, okay, we can just do that right now. There are 7 crises. So when we have the aplastic crisis, usually caused by parvo B19 virus. So what are the features of this aplastic crisis? We can have severe anemia, pallor, weakness, almost the same symptoms, and we can also have reticulocytopenia. Another crisis is the hemolytic crisis, as we have already understood where hemolysis comes from. So the features will be the anemia because of the hemolysis, jaundice, and dark urine. Hemolysis is just when the red blood cells are destroyed, increased bilirubin, jaundice, and all that, dark urine. Okay. Another crisis we have, it's the megaloblastic crisis, hyperhemolytic crisis, and sequestration crisis. We have infectious crisis due to the hyposplenism. Okay, for sequestration crisis, it's the sudden pulling of the blood into the spleen. We have this extravascular system, that is the spleen and the liver. So when there is sudden pulling of blood into the spleen and the liver, which is precipitated by dehydration, clinically there'll be pallor and hypovolemic shock. Okay, no much details with that. So the acute abdominal pain in this, it's because of the organomegaly, that is the liver, enlarged liver and enlarged spleen due to the increased sequestration. All right. So the infectious crisis due to the hyposplenism. So there is decreased antibodies, decreased phagocytes, and all that. So the common organisms, commonly they are encapsulated organisms like pneumococci, Haemophilus influenza, pneumonia, Salmonella typhi, and all those organisms. So those are the 7 crises, and the other one, the acute chest syndrome. Okay. So what are the complications of this sickle cell disease? So the early complication, we can have severe infections, osteomyelitis because of the Salmonella typhi. In case of the infectious crisis, we have the encapsulated organism, and we have mentioned Salmonella typhi tends to cause osteomyelitis. Splenic sequestration for the sequestration crisis. Another complication is stroke. Acute chest syndrome. For the chronic complication, we have functional asplenia, gallstones, chronic kidney disease. Okay, because of time, I can't explain one by one because the video will be very long. So I'll just going to list them. We'll discuss them maybe a later date, or you can just check them out. So avascular necrosis of the femoral head, that is the head of the femur, pulmonary hypertension, retinopathy, leg ulcers, delayed growth and puberty, heart failure, and all that. So what are the investigations that we are going to do? Lab tests, complete blood count. We check for anemia, we check for, the hemoglobin, anemia, we check hemoglobin to confirm or rule out really anemia. We check for the WBCs because of the infections. So basically the hemoglobin will be low because anemia presents with low hemoglobin, increased WBC or white blood cell count because of the infections, increased platelets. For peripheral blood film, there'll be sickle cell, target cell, or Joey bodies, polychromasia, nucleated RBCs. You can just go and check them out. All right. The reticulocyte count will be increased. We've said due to increased destruction, there'll be increased production. So reticulocytes are the immature forms of the red blood cells, so there'll be increased production of the reticulocytes. So for bilirubin, there'll be increased and conjugated bilirubin. LDH will be elevated, all that. So for the test to confirm sickle cell, we can start with sickling test. You can go and check how it's done. A solubility test, and the gold standard, it's hemoglobin electrophoresis. It's the gold standard to diagnose sickle cell. So we are going to check if there is HBS. Yeah, go and check how it's done. Okay. And other cells. So typically in the electrophoresis, the HBS that you've talked about will be more than 90% and all that. So some imaging can also be done to rule out the other organs, example the chest, the kidney damage, and the liver and all that. So we can have chest x-rays, brain CT scan, Doppler, abdominal ultrasound to check the hepatosplenomegaly, echocardiography to look at the heart, and all that. Okay. So for the management, how do we manage sickle cell? So for the general measures, first, adequate hydration, because we've said if these people are dehydrated, they can have a crisis because it's a predisposing or a risk factor, dehydration. So make sure these people make sure they are adequately hydrated. Another one, it's good nutrition, folic acid supplementation. You vaccine against this, we've said the encapsulated organism, that is pneumococcal Haemophilus influenza. There are vaccines to that. So ensure that they are given the vaccination. Malaria prevention, because we've seen that sickle cell is more in the malaria endemic zones. So, and there is vaccine for malaria. So ensure that they are vaccinated. And health education, educate the community about sickle cell. If people want to get married, make sure you provide genetic counseling. Let them know about sickle cell because it's a disease that it's so expensive to manage, the pain crisis and all that. So health education, people should be aware of sickle cell, because once a baby acquires sickle cell, it's a disease that you will handle for the rest of the life of the child. So it will be quite cumbersome to the parents. So ensure you go for test or screening for sickle cell with your partner before you can give birth. All right. So we can also administer analgesics, because we've said that there is that vaso-occlusive crisis, the pain, it presents with very severe pain. So you can give analgesics if it's mild pain. Paracetamol and ibuprofen will help. If it's moderate pain, tramadol, codeine. If it's severe pain, they'll have to be on morphine and all that. And then you can, for blood transfusion, it's indicated on the acute chest syndrome, stroke, splenic sequestration, and all that. Okay, I'm just avoiding a lot of information. And also hydroxyurea, folate. We've said we administer folate. Hydroxyurea should also be administered. So it increases HbF, the fetal hemoglobin. It reduces the vaso-occlusion. It reduces pain. It lowers transfusion requirements, and it improves survival. For the curative, maybe transplant, stem cell transplantation, the hematopoietic stem cell transplantation. Yeah, we've already talked about prevention, carrier screening, premarital genetic counseling, as I've talked about, newborn screening, early penicillin prophylaxis in children, routine immunization, pneumococcal vaccination, and prompt treatment to infections. We have already mentioned this. So I think that will be it for now. Yeah. So with comprehensive care, as we have talked about, hydroxyurea should be administered, vaccination, infection prevention, adequate hydration, and timely management of complication. All right. The patients can survive up to adulthood. Yeah. So for the risk factors, as we've talked about, so the management, you just avoid the risk factors that we've just mentioned. Yeah. So for now, I think that's just a good overview of sickle cell. Unless there's any other question. Mhm. Unless there's any other question. For the sickle cell trait, they are they are mostly asymptomatic. Okay, mostly asymptomatic. It's just a trait. But if they're exposed to severe hypoxia, severe oxygen, like when there is very reduced oxygen, they might be symptomatic. Okay, so for the trait, mostly they are asymptomatic. Okay, so unless there is any other question, so you can educate your people, your community about sickle cell, mostly the premarital counseling. Because as you have said, in Kenya, the coast region and the kunaitwaje, lake region, the malaria endemic zones, if you want to get married, go for premarital counseling and screening. Because if both of you are carriers, or if both of you are sickle, giving birth to a sickle child, no, we can just avoid that kind of trauma if we can. Okay. Yeah. So I think that will be it for now. Yeah. So see you next time. Okay. I'm giving you a minute to subscribe. Finya your subscribe button. Subscribe. Follow. Okay, share this video. Okay, you've done that. Like. Yeah. Now, thank you all for tuning in. See you next time as we discuss another topic. Bye.